Hi, my name is Moji. I'm from CPF British and Peterborough NHS Foundation Trust. The question is, thank you so much for a lovely presentation, but want to find out what's your thought around wearing of FFP3 mask in the clinical area when looking after patients generally, because we don't know what they're carrying. And as you pointed out during the presentation, some of the conflicts in the guidance that is out there. UK resource says if you're resuscitating someone and they are COVID positive, you must wear FFP3 mask for chest compression. And for staff working in the community, they will never know whether the patient has COVID or not. Most of we stop testing. Yeah. So what's your thought about that? And the voluminous of hours of, fit testing the staff who will probably never use it.
Yeah, we're in a difficult position at the minute in that we haven't got guidance that makes sense, right? And I write to the chief nurses regularly. I've got a draft on my computer that they're going to get in the next couple of days. But please write and ask them, why does our infection control manual not make sense? And it's easier now that they've come out and said the dichotomy is wrong. So give us the right, you've had 8 months. Give us the right, 9 months and a couple of days. Give us the right precautions. So, they've got probably dartboards of me and my picture up there. But other people have got to do it. And just say there is a petition for for indoor air quality to Parliament, for schools and for hospitals. So find it, and again, if you follow me on it, you can get it that way, because I've retweeted it a lot. But healthcare workers need to say, I think there has been a triggering. I think there's a bit of post-traumatic distress that has been caused, that when people see people in a mask, I can't go back. But how do we make them safe? And so we've got to say, okay, we're not where we were, but we are where we are, and this is what can make us safe. Can you wear an FFP3? You can wear it when you like, but I think we've got to get the guidance right. But if somebody's coming in with a respiratory infection, I'd have one on. Even I don't care if I buy it myself. Come and show me a paper that says it's wrong, because nothing out there. And I've been reading the papers.
Yeah, thank you. So there is also a lot of work going on around supporting practitioners as well as infection prevention and control nurses, because this is about the individuals as well, to do a risk assessment. It's not complicated. It shouldn't be seen as being complicated, and it is something that evolves and changes. And the other thing that we're really very strongly lobbying for is PPE that is comfortable and fit for purpose, that allows people to lip read, that you can wear for periods of time, that doesn't cause harm. Unfortunately, we are where we are with the PPE that we have, but that's not where we want to go. I'll take one more question, please.
Thanks for your talk. Firstly, just say that I do agree with you about airborne transmission. Don't completely agree with everything and the way it's portrayed in terms of whether you can completely mitigate risk in every situation. And there's a question about whether ongoing, how immunity plays a role in a population level, and potentially if you try to prevent all transmission, what might happen then when you got infected, because you can't prevent infection completely, and there's something to be discussed about vaccination as another preventive measure. But the thing I was going to actually wanted to talk to you about was during the pandemic, when we looked at air changes on the ward, then they're not. It's quoted as 6, but there's not actually any measure to achieve 6. So you either open the windows to try and get some air changes, which you can't do in the winter because it's freezing, and if you do it in the summer, the air is still. So there's not really, I don't think, any hospital built where the normal ward has any measure of air changes. So that's something that probably needs to be built into the environmental construction.
Yeah, I'll defer that bit to the next speaker. Maybe didn't know he was going to get that question, but I would. With regard to what I was trying to say, is this bit about, it's kind of if we Paretoed all of our options for reducing. What one thing would most make a difference at the minute. And we haven't been collecting the data on transmission, so we don't know all kind of where it's transmitting. How it's transmitting, is it close to the source, is it far afield from the source? What's going on? So we need better intelligence, but it's in the air, and I would go for indoor air quality first, but if you are looking after a patient with COVID who's thought to be infectious, I would go, there's too many people got injured with looking after the most infectious patient who was the auxiliary nurse doing a bed bath, somebody who's infectious, somebody who's coughing, very symptomatic, in a cupboard, not great ventilation, and everyone's dressed up to the nines in an intensive care unit where they're less infectious and they've got great air quality and they've got filters on everything. So I think we missed our greatest risk was to the person going into the room for close contact. I don't like that term, close space, shared close space for a period of time. And the prevention priority is not going to be the same everywhere. And that's the bit we need to localise. What's the problem in your unit? Where is transmission happening? If it's not happening at all, maybe you've got the ventilation. We have to learn from the good and the bad. What's making a difference? So we're baby steps, which is a ridiculous thing to say at 5 years in.